instrumentation would be sort of tracked with that. It's a pretty neat little survey. You do that in the OR.
I would be OR.
Yeah, the OR.
Mm-hmm.
It's a pretty neat surgery, so if you ever had a chance to watch one, it's pretty neat to watch a stereotactic radiosurgery for an evacuation of brain tumor.
And you said it's in like conjunction with like CT or
Yeah, because the computer. So what the computer does is you load it onto a program, and the computer allows you. It almost gives you a virtual environment where you're like going, okay, if I go in this trajectory, I'm going to miss that vessel. If I go in this trajectory, I'm going to miss the speech center. And that kind of stuff. So it gives you exactly where you are. And in the middle of surgery, especially with resections and stuff, you'll put the tracker in there, and then you'll know how far you are in the brain tumor. And so it's a really neat technology to have. So if you ever had a chance to go down and see a stereotactic radiosurgery for evacuation of brain tumor or something like that, it's pretty quick.
when Tracy comes back, can you not mention that we didn't know that?
Okay, no, I won't.
All I'm asking.
We're all
No,
embarrassed.
no,
We're all
But the answer is I have no
So
idea.
again, the Misty trials, we're looking at these deep hemorrhages, basal ganglion hemorrhages. You got to go through a lot of brain tissue to get to that, and they're about a centimeter or 12 millimeters in diameter, so it's not small. Again, Misty 3 looked at can we affect outcomes in patients with an ICH of greater than 30 cc's. Okay, neither of these trials showed significantly improved outcomes at 1 year compared to what we were already doing. And then you get into Misty 3, and Misty 3 had the same thing. The 12-month modified ranking was similar between the groups. But here's what I would say: in 60% of the treatment group that met, if you could get most of the blood out and only leave less than 15 mils of hemorrhage in there, then you had significantly higher odds of getting that modified Rankin 0 to 3. Okay, but you had to get out all the blood, and that's challenging. So in patients where they were able to do that, those patients actually did better. Okay, so that's the caveat to these deep hemorrhages, is you've got to be able to get the blood almost all out, and that's hard to do. The Enrich trial still stopped for efficacy. They did think that the surgery group was better. However, again, those lobar hemorrhages sort of drove the results, because if you're closer to the brain surface and you take that hemorrhage out, then you have to go through so much stuff. And so the deep hemorrhages are still an issue. Okay. I mean, early surgical treatment, yes, is moving into mainstream management. It is. I mean, at least now they'll consider it. Before my neurosurgeons would even consider it. Here's what Ann's going to probably talk about tomorrow is code ICH. Okay? And I'm not going to steal her thunder. But when we look at a protocol approach to treating ICH, similar to what we do with acute ischemic stroke, we haven't had any time metrics on ICH on time to blood pressure control. What is the time to CT for an ICH? We don't know. I mean, we treat it like an ischemic stroke, and then we see the hemorrhage, and then it's kind of like, okay. Again, we're giving some metrics around reversal agents, giving some metrics around neurosurgery consult, a head position, serial NIH scores, again, making that part of that assessment piece that Wendy Dusenberry presented and has written about. Getting that repeat head CT, and then again monitoring procedures. So you're going to hear more about that when she comes and sees you guys. Let's switch gears and talk about subarachnoid hemorrhage. That's a big subarach right there. Okay. In the U.S., about 3 to 5% annually, or 30,000 Americans each year. Black Americans are high risk. When we look around the globe, it's significantly different in Finland and in Japan specifically. right? So it can vary between countries, interestingly enough. And the incidence of subarachnoid hemorrhage increases with age. It's most common between 40 and 60 years of age, okay? It's more common in women than in men. Don't know why. When we look at outcomes, these are our sickest patients. I can tell you right now, these are my most fragile patients, these patients. Mortality rates can be upwards of 45%, okay? Especially in the first few days after the initial hemorrhage. 12% die before receiving any medical attention. 12% are misdiagnosed because they come in with a headache or something like that, and nobody gets a CT scan. Some of our aneurysm factors in terms of influencing outcomes have to do with the size and whether it's a posterior versus anterior circulation. Some of our patient factors that influence outcomes are the initial hemorrhage severity, and that initial slide, that patient is probably going to do poorly with all of that hemorrhage in there. Age, gender, time to treatment, and also their medical comorbidities. Some of my hemorrhage patients have other things that have influenced sort of palliative care discussions and that kind of thing with them. It's not just been one thing. And does your organization, do they see these patients? What is the experience of the endovascular surgical specialist? And I would even add to that your neurocrit specialist, because these patients, once the endovascular people are done with them, they really don't know how to manage the neurocritical care part of these people. And so that's what really gets you, because these people will go into DI, they'll go into all kinds of vasospasm. I mean, they'll do all kinds of things on you, and you need a good neurocritical care team. Do y'all have a separate critical care neurocrit team here?
No.
Yeah, I have maybe one or two. I have one or two, like, specifically neurocritical care people, and I relied on that. They were locums, and I hated when they left, because now I have pulmonary critical care.
But don't we have some of our pulmonary critical care
I mean-
being certified in like?
I
They
don't
took
know
their
what
board,
their,
probably took neurocrit boards.
That's what
yeah,
they're
I mean,
doing.
I don't know what their, like, all their certifications are, all of them are. I just know that when it's a bleed, that's when home
I
gets
think we
involved.
have a couple that are actually gonna get neurocrit certified.
Yeah, see, and so what I have seen, because I've seen probably 24 locums in a hospital with neurology,
Mhm.
is there is a difference in somebody who's neurocrit trained and somebody who just sits their boards.
Mhm.
We have that too. We have people who just at their boards, and that's helpful, but they haven't seen all the ins and outs of stuff of how sick these patients are.
Sure.
I will not speak ill of our pulmonology team. I'll say that.
Yeah.
They're-
Let me tell you, my strictly pulmonologists, intensivists that like manage vents and stuff, they don't want any part of this.
Well, ours do this.
Huh?
Yeah,
All of our,
ours are, I mean, they're in conjunction with
Are they?
neurology
Yeah.
Okay.
or neurosurgery,
Okay.
but
Okay.
yeah.
Yeah, so I have two different groups of intensivists.
Mhm.
I have the intensivists that will admit our ICHs and all that, and I have the intensivists that like see patients on the floor and stuff like that, and they'll have patients on the ventilator. And they're good physicians, but they don't want anything to do with this.
Yeah, ours are catch-all between like
Yeah,
floor clinic and then ICU
Oh, wow.
exclusive, and then I mean in ICU they're kind of like jack of all
they're
trades
that's right,
intensivists,
that's
but
right.
outside of the hospital they're
Yeah,
exclusively, so
exactly.
they have a
Yeah.
tough job.
Yeah, so we have some, a similar situation. It's hard to get somebody who's neurocrit, trained, honestly. Okay. All right, risk factors, hypertension, smoking, heavy alcohol use are independent risk factors for subarachnoid hemorrhage in the US. We also have a season of, we think it's associated with, atmospheric pressure changes, but anyway, there definitely is a season. Genetic syndromes like autosomal dominant polycystic kidney disease and type 4 Ehlers-Danlos.
do we know when that season is? I'm sorry, this is random.
Winter
Yeah.
and spring.
Yeah,
We
and typically it's in like
Winter and spring.
November. I mean, I see them in like November and October, November in my area.
our worst month year to year is August, where
Oh,
we
is
will
it?
have 8 to 9, like our
I'll
record
have
is
a bunch
like
of 'em
10
at one
EVDs in the
time.
unit.
Well, isn't it just when people drink more?
But it's,
Maybe
it,
we-
it,
we-
I mean, that's a
Like,
great
maybe they're,
point.
maybe they're getting out from the winter, they don't know, yeah, or
Kids
they're
went
getting
to
out in the
school, we're
fall.
done.
That's
Yeah.
right.
You get celebratory.
They can't see.
Yeah, for us, it's more toward the winter, it's like October, November, and then we'll have a slew of them.
Maybe more people are doing cocaine than we think.
Oh,
We're just not
yeah.
testing.
listen, I'm in
Most people drink
Bethlehem,
all
so.
I know, I was so shocked.
Okay.
Sorry.
The majority of these aneurysms, and here in just a minute, I would know this. The majority of these aneurysms are found on the large arteries at the base of the brain that make up the circle of Willis. Okay, so I would definitely know that, for sure. And we're gonna look at which ones are more, prominent.
Sorry, can I get a picture of that?
Oh, yes, you can, yes,
It's all
sorry,
right, but-
yes.
It's not.
Oh, hang on a minute, sorry.
So
Yeah,
the
right there.
majority of aneurysms
And we're gonna look
that
at
are
a different,
causing subarachnoid hemorrhages are circle of Willis. Okay.
yeah, associated with circle Willis, yeah, Willis, listen to me, Willis. Okay, ACOM-A is the most common. A lot of pressure coming off of that of that ACA, and so the ACOM-A, ACA is the most common. The takeoff from the PCOM, from the ICA, which is right here, is the second most common. Yep. And then the third most common is the MCA. That's where you get the isolated hemorrhage in the Sylvian fissure, and I'm like going, what's going on there? Okay. You might see that again. Now there's some different configurations of, and this is a saccular aneurysm, you can see that. Yep, it's right there on the ACA. And you can get some fusiform, which are related to atherosclerosis. The myconic aneurysms are due to infection. So we get a lot of myconic infections, like people with IV drug use, or maybe they have an LVAD and they have a drive-by infection or something like that. And traumatic, you can get some traumatic aneurysms as well. Pretty rare to get that. But again, the first three are pretty common. Okay, here's your Berry aneurysms. Here's your sort of your aneurysm configurations here. Your Berry aneurysms are the things that you see the most of, right? And then you have a Berry aneurysm on the bifurcation. This particular, on the bottom part where it says a broad-based saccular Berry aneurysm, you see that broad base off the vessel from that aneurysm? It's a broad base. That cannot just be coiled alone. If you've ever been in the IR suite, they pack the angio, and they put all the catheters up there and all that, and it's basically packing spaghetti. Packing coils, and it looks like spaghetti. This one on the bottom is probably gonna need a stent across it here to keep the coils in. So it's gonna be stent-assisted coiling here, because otherwise the coils will dip down in here, and then you'll chunk clots everywhere. So when they need stents across the coil, that's why they need them. So if you have a stent-assisted coiling, that's why. And then the fusiform aneurysms, there's not a whole lot we can do about those. So it just depends on the interventionalist on the fusiform. But those are from atherosclerosis and just the weakness of the wall. Most are asymptomatic prior to rupture, okay? And they may present with the mass effect. So on that bifurcation where the PCOM-A kind of comes off of the ICA, your third cranial nerve runs right through there. And so when you have compression on that cranial nerve, you can have dilated pupil without the aneurysm rupture. And this was described way back in 1929. So if you want to know the size, 7 millimeter is the size that is most commonly associated with rupture at over 7 millimeters. Okay, that's a big aneurysm right there. Again, worst headache in my life is described by 80% of conscious patients. And a lot of these patients will say, yeah, I had a headache 2 weeks ago. And I didn't think too much about it, it went away, and then they present back to the ED with this worst headache, okay? It can be accompanied by nausea, nuchal rigidity, a brief loss of consciousness, and focal neurodeficits. So it can be accompanied by all those things. What do you do with them? It's always a non-con head CT. But if it's negative and you have a pretty good story, that's when the ED physicians will get the lumbar puncture, okay? CT angiography is pretty sensitive, especially when it's pretty close to when these patients have this headache. But if you wait a long time, that CT can sort of, the blood can dissipate, you won't see it. And you can have small aneurysms and the CTA won't show it either. So anytime I have somebody who has a good story and I have a non-con head CT, and maybe a CTA that's kind of a critical, I'll consult our interventional team. Okay, here's the HUD has differences in the scales. I would know this. If that's not in your book, I know it. The HUD has or the WFNS scales are used for us. We have to put them in there before we do any intervention, otherwise the stroke coordinators get mad at us. And I get mad at my doctors. I'm like, you have one job. One job is to go to angio suite and you can't put a HUD has.
On page 95.
Okay, y'all got that? Yeah, you might see that a little bit. You gotta get control of your blood pressure in these patients because rebleeding of these aneurysms carries a 70% mortality rate. And honestly, if we get their blood pressure controlled and we get some of these factors controlled, we can easily control that risk, okay? The definitive treatment is endovascular or surgical clipping. Okay. We typically try to get them treated within 24 hours. Again, prior to that definitive treatment, it's gonna be blood pressure control, bed rest. Now, I will tell you, I have some people who use antifibrinolytic agents. They use TXA. Well, they use TXA on everybody. We use TXA on our hemorrhages. They use it on everybody. But anyway, it doesn't do anything to reduce poor outcome. Again, it's typically historically been used as a bridge. But again, I have some people who, especially if they're going to get